Welcome to the Brain Development Workshop. I hope that's where you're all supposed to be. It gives me great pleasure to introduce our presenters today, Dr. Gabriel Civiello and Dr. Stephen D. Giovanni. Yay! Dr. Gabe is a pediatrician at the Franklin Health Pediatrics in Farmington. He received his medical degree from Dartmouth Medical School, where he received the Saul Blattman Award for Excellence in Maternal and Child Health. He completed his residency and was a chief resident at the Maine Medical Center. Dr. Gabe also serves as the Maine Health Clinical Advisor for the Child Health and Raising Readers programs and is a father of 4 children. God bless you. Dr. Steve is a practicing pediatrician with a passion for improving health outcomes for children. Dr. Steve has significant experience in both private practice and academic pediatrics. He is currently the medical director for the Maine Medical Partners outpatient clinics. The clinics, which are internal medicine, pediatrics, iMed-Peds, and virology, have a dual mission of serving a diverse, underserved population while providing an excellent platform for medical education. In addition, Dr. Steve has extensive experience with population health and quality improvement projects at the MMP clinics across the Maine health system and at a state of Maine level. Dr. Steve utilizes a quality improvement approach built upon mental health integration, community collaboration, and data utilization to improve the experience and outcomes for patients. He is currently focused on developing programs to prevent, screen for, and treat ACEs across the Maine Health Pediatric Service line. Welcome, guys. Thank you.
Thanks, everyone, for being here for the seminar today. As we're presented, both Steve and I will be talking a little bit about what is a little bit of a melded topic, but I think we both think topics that really do lend to each other, which are talking about early brain development and adding in the concepts of ACEs, which I think most people are probably aware of now just with the acronym, have adverse childhood experiences. With a lot of research behind that now, and early literacy, and specifically early literacy in the context of the Raising Readers program, which is how, as providers, we interface with a lot of children in the area of early shared book reading and early literacy. So I'll jump ahead here with what we'd like to talk a little bit about today, which is to discuss early brain development and how different childhood experiences both positively and negatively affect that development. Also review a little bit of the scope and effect of adverse childhood experiences in general and in the state, which Dr. Steve will do much of that about. Raise a little bit of awareness of how raising readers can promote resiliency through bonding and early literacy. Hopefully we'll convince you a little bit of that by the end of the presentation today. And show the example of how in our worlds as pediatricians, discuss early literacy and ACEs with families in practice. So kind of trying to open a window a little bit about how do we talk about, what is our role and how do we talk about this stuff in our practice setting. So first, slide, and actually this is something that I, believe it or not, I probably do believe it, is trying to convince parents and the people that I'm seeing in practice why early reading is important. I think probably in this audience, everyone's like, oh yeah, probably, we know that, but probably, so working with parents of young children, you could imagine, the 4-month-old that comes in, trying to convince the disadvantaged in many cases, or maybe a parent that has very low literacy levels, or maybe, to be honest, maybe a parent that can't read either very well or at all. Trying to communicate a message to get across why early literacy is important and what they can do as parents. So the message is, books build brains, right? So that's a simplistic message, but it's one that we try to get across in practice. This is this is just a little concept slide, more on the side of the early brain development piece. And actually, it's interesting, the keynote speaker this morning, I talked a little bit around brain development as well. And so this talks, and this kind of neuroplasticity and neural networks. So this talks about neural circuits and the wiring, kind of bottom-up sequence. So it's amazing how many. So you're born with basically the number of brain cells, neurons that you're going to have, basically throughout life. The real deal, the real thing that is experience dependent and changing over time are these neural connections or synapses. So 700 synapses formed every second in early years. And as I mentioned, the big deal is experience dependent, during that time. So this just goes through the roles of how critical that early time period in brain development is. Again, I know I'm speaking a little bit to the choir here, but both for sensory pathways, visual learning, hearing, language pathways, and then higher cognitive functioning, executive functioning, for instance. But a lot of those pathways are developed very early on in life, right? That kind of critical first 3 to 5 years of early brain development, where the majority of the synapses and the connections are made. Really, after that time, it's mostly, so pretty much most of the connections are made like very early on in life in the first 3 years. And then there's a lot of pruning that happens, again, experience-dependent pruning, which means you make this massive amount of connections, then depending on experiences, things that are not used anymore, the connections that are not useful are kind of lost. And the ones that are reinforced remain. I think of probably the best example, or one that from a sensory pathway standpoint, people can kind of think about, is like the visual system, for instance, and we talk a little bit about sensory pathways. So a child that is born with a lazy eye, for instance. So they'll, the visual, that people don't like to see double vision, right? It's very disturbing. And if you're born with a lazy eye for a portion of the time or all the time, you're seeing double. So what will children do? So in an experience-dependent manner, the child will start to ignore one eye, so that they only see one thing. And there is a dependent period early on in life. And after that period of time passes in which you can help that eye, whether it's through things like patching, surgery, whatever what that thing is, there's actually a loss going forward about if it's not addressed in the early time period. It can't be redone. Meaning the pruning process or the forgetting of that wiring happens such that after, and particularly for vision processes, probably somewhere in the 8 to 10-year-old range, there's not much you can do after that, and that's just what they'll end up with for vision. So I wanted to highlight a couple studies that, again, get at the question, not the question, but the argument that I have to sometimes posit for parents about why is early reading important? Why is it, what is it, and what are some of the things that we know? So, so this is a study that looked at linguistic kind of experience early on in life, and this is a Science article. It's quite old now, but where the researchers showed that there's actually, they look at 32 U.S. infants, 32 infants from that were Swedish infants, and looked at kind of prototypical sounds for each language. And then they were recorded, and they played slight variations that were made. And each infant group recognized variants of the prototype preferentially for their own language at 6 months of age. So I mean, just thinking about like what when that timing of recognition happens and helping to give us evidence to play into our mission of, they experience more than you realize at this young age. This is another slide, actually by the same researcher as part of a review that talks about the timing of some of the developmental speech and language recognition. And I'm sorry, it's a little hard to see and a little much up on that screen. But again, it's really just an example to point out at what a really unbelievable early age, like at 6 months, the language-specific perception of vowels, detection of typical stress patterns in words by 8 months, language-specific speech production 10 months. So it's just, I think, again, pushing towards when I'm convincing parents or when I'm trying to talk about why this is important early on. This is just another kind of interesting research example that around this kind of early experience-dependent brain connection making. So this is a little research study where they looked at 12 subjects that were either early, bilingual speakers versus those that were late bilingual, so learned a second language later in life. And then they did functional MRI studies such that they looked at what areas of the brain light up with using the different languages. And for those that are late bilingual speakers, the second language is basically stored in a different area of the brain than the first language. You can see that's the image on the left. Whereas the early bilingual speakers, you can see the language is stored in the exact same place in the Broca area. So with incredible overlap. Again, speaking to the point of that early bilingual experience actually stores in a different part of the, stores together in the brain versus, and this is kind of intuitive in that, like, you think, well, it seems to be harder for people to learn a second language later in life versus those that grow up learning. That's, and this may be a portion of why that's true. It's actually stored in a different place. This is just one other study that looks at, was looking at more of what do we create for patterns when we give the recommendations around reading early to kids. So 87 typically developing infants, 4 to 16 months of age, found that shared book reading at 8 months was linked to later expressive language abilities at 12 and 16 months. Again, not incredibly surprising, just research to show what I think we probably all suspect. But also importantly, that shared book reading at 4 months was related to shared book reading at 8 months. Again, not incredibly surprising, but again, positing the message of you develop a pattern of shared book reading early on, and that perpetuates through later, and then helps to lead to the expressive language abilities, right? So next is how does this play a role in our overall conversation around what does early book reading help to do? So I will start to posit that shared book reading helps building positive relationships, right? So again, we just had a keynote speaker talk basically about relationships, right? So as I was hearing that presentation, it got me thinking about he's talking about kids that are probably, are school age, right? That's what he was really talking about this morning. But I think we'd all like to think about what can we do on the front side, right? So yes, I think it's super important to learn how to talk to our troubled and how to react and how to help our troubled, disadvantaged school-age kids. Absolutely. The other side of that is is there anything that we can do to try to push towards early on what interventions do to try to help a child from the beginning not be, labeled a troubled youth, right? Like, what are the things that we can do? We can't do everything, but what are the things that we can do? So really trying to promote, and in what we can do, pushing towards shared book reading, if only for a relationship standpoint, right? It's a time together, and what do relationships build? Trust. Again, and it was one of those words that we were just talked about. Like, these kids who have a tough time later have difficulty with trust, and trust leads to confidence, and confidence allows for a child to better be able to explore and learn. So it's a little bit of a step down the pathway here, but again, every little bit that we can do to push that step in the pathway, we think is worth investing in. So I'm gonna make a little transition here and let Dr. Steve talk about some of the other side of things, and then I'll come back and talk about some of the more evidence behind what we do kind of in practice. Thanks, Steve.
All right, good morning all. So mine's going to have on the kind of negative side, and then trying to figure out how do we build resiliency or islands of success or strength-based to go the other direction. Putting in the context within Maine Health, we are trying to, our three main goals on this project are prevent adverse childhood experiences, screen to find out if they have occurred, and to treat if they have. And so it's a major change in pediatrics from if you've brought your own children or you remember your own experience within pediatrics. So hopefully, if we're successful, it'll be a massive cultural shift of how pediatrics works. So what a lot of what I'll show today is a lot of the trainings we're doing in offices and some of the tools we're putting in place, and then also putting the call out there, is there ways the community and us can partner more? And we've already initiated some of those things around some of our partnerships with child developmental services. So this is some of our infographics. So basically saying 1 in 4 children right now, if you screen them, have experienced 2 or more adverse childhood experiences. 60% of kids in the US are exposed to violence, and we're not talking media violence, we're talking either direct towards them or have witnessed. And we know definitively, without a doubt, that seeing, hearing, or experiencing violence is bad for children. The difference, the game changer for Maine Health and the medical community is we actually now have several evidence-based trauma treatments that are proven across the child age spectrum to make a difference and improve outcomes. You wouldn't screen before in a pediatric practice if you couldn't do anything realistically. So now we have tools in our toolbox to kind of help move families forward. I'm going to do a little teaching on adverse childhood experiences. My apologies if this is repetitive for anybody, but I'm going to throw it up there. So massive size study done 15 to 20 years ago by Drs. Anda and Folletti. They interviewed 17,000 adults, asked them about their current health, and then asked them about their childhood, and then compared those, okay? First thing that came out, and this was a middle upper income insured population in California. So how common these 10 categories were: 28% reporting having been physically abused, 21% sexual, 17% emotional abuse, living with a caretaker with substance abuse, so think about our opioid crisis, loss of a parent, especially around separation, divorce, or incarceration, living with a parent with mental illness, domestic violence, which is a major driver of poor health outcomes in Maine, and or, as I said, the criminal behavior of a parent. Just to highlight, we're now starting to gather this data in Maine. It's depressing data, but it's an opportunity is how I try to always think about it. So they, on the...
It's not a mistake, it's an opportunity.
Yes. So this past year, as part of their screening for like risk factors for adolescents and teens, they put in adverse childhood experiences in an anonymous manner into the screening. And the 3 or more ACEs was 20 to 37% of high school students. So that is just a mind-blowing number. And then significant changes within some of the counties from a low of 20 to all the way up to 37 to 40% of kids, and the females are reporting 10 percentage higher. So what does that do, and why are we trying to change pediatrics and also education and how we handle children? A lot of trauma talk in the first talk. What I'm trying to say is, I think it's incredibly important to let's deal with the kids who are school age. From a public health point of view, where's the poison coming from? And going earlier to prenatal, to the earliest childhood in their brain development. So Center for Developing Children in Harvard showing, okay, developmental delay. We always screen for developmental delay in pediatrics. We weren't screening for the environment in addition. And show as you go up in ACEs, the risk of developmental delay, which is just genetic based, is pretty darn low. 5% up to, as you get 4 ACEs, 5 ACEs, 6 ACEs, 50, 60, 70% chances of developmental delay. The major impact on life is around the mental health side of this. So your chance of having a major depressive disorder, if you have 0 ACEs in your life, is 15. If you have 4 or more, it's greater than 50%. It's an 800% increase in risk of suicide attempt at 4 or more. Anxiety disorders is even higher. Substance abuse, so think about Maine once again, going from a 10% chance of having substance abuse disorder up to greater than 40%, 1,000% increased risk of injecting drugs if you have 4 or more ACEs, and then the connections to ADHD and impulse difficulties. And this is what you all probably know is academics directly related. And each one of these, what we like to see in research is that stepwise fashion. So in trying to prove a correlation, if all of a sudden you went 1, 2, and it dropped, and then back up, but almost none of these slides, and there's hundreds of them we can show, of, if you have 2 or more report, 71% in that school district of having some academic or behavior issues. Goes all the way through life, and so you look at impaired worker performance, so it affects our jobs in schools, places we work. And we call this the trauma lens, so trying to think about people in a different way of what happened to them, not why they're behaving currently, but what happened. So once again, like an immunization, incredibly protective if you have no ACEs. You're not most likely going to end up homeless in your life. You have a 1.3% chance, and you have 6 ACEs, you have almost a 25% chance. I hope that cheered everybody up. That data changed my career as a pediatrician because I was like, what have I been doing? I've been trying to give, immunizations are still great. But, we're trying to do all these other things and we're missing the boat, so let's, I love the Thrive by 5 model of when we hand the kids over to kindergarten, are they in the position to thrive? It's not our whole job, but it's something we really should be focused on. This is the public health model of the situation of you have your adverse childhood experiences, impairment in social, emotional, cognitive skills, and changes in your body and brain, high-risk behaviors, disease, and you have a chance of dying 20 years younger if you have 4 or more ACEs. The problem with the medical community, we love spending money up here. We're really good at that. And pediatricians are always asking, give us a little money for down here. And so that's the goal. Maine Health has actually stepped up in Maine Medical Center. They've put it on their plans, and they are investing at that lower level to see if we can change trajectories. So I'm very excited about that. Trying to explain stress responses. You want some stress in your life. You have to learn to handle stress and change and make decisions and things like that. So, in a mild stress, brief increases in heart rate, a little bit of stress hormone gets released, you deal with the situation, goes back down. You get a serious stressor that's temporary, and you have supportive relationships, and you haven't had a lot of trauma in the past, things will go up and go back down, but won't affect your long-term development typically. What we call now in pediatrics is toxic stress, which is prolonged activation of the stress response in the absence of protective relationships. And so that's trying to, if we can prevent that, if that occurs, how do we build those protective relationships? Dr. Gabe already talked about, you can build connections in the brain by reading and other interactions. You can take them away, basically, through trauma and neglect and things along those lines. So that's just a shot of the different connections in the stressed and non-stressed brain. They can show, so the parts of the brain in a healthy, non-traumatized, lots of growth in the prefrontal cortex, which is your decision making and your higher level skills, your hippocampus for your memory. And then in an abused brain, those areas are not developed and your fight or flight sections are hyper. There's actual increase in size and activity. This is brutal. You know, the brain needs experiences to develop, so severely neglected brains don't develop. The crazy thing is it actually affects your DNA, and because there is definitive generation to generation. Part of that is your experience, but actually they showed on the chromosomes, the parts that protect the ends that decrease the chance of damage to your chromosomes are shortened when you've experienced a lot of trauma. So a lot of science coming out of it. It helps that there's science because then I can get the medical providers to pay attention some, and that's one of the keys. So that's just to give you a highlight that we're showing that presentation, that initial introduction all over the place in the medical world. We also then start to talk to them about, we can use the invisible backpack of saying, you know, the kid shows up at school, what's in that backpack, how much trauma has been experienced, how much self-confidence do they have or loving relationships, and how much that affects. But it's invisible, you can't see it. And then it doesn't mean because you had ACEs that you're going to have these things occur or traumatized. It's a risk factor, and there's many things that can change that trajectory. So we know ACEs are incredibly common. Not everybody who has ACEs has all those things I outlined. And the things that really impact it, so with the age of which you have the trauma makes a difference. And initially people thought, oh, they're kind of pre-memory. That's a good age to have the trauma compared to later. And that's the age that most affects the development of the brain and those kind of real internal areas. The own child's own temperament, the perception of danger. If the child thought they were going to die, that is a very strong predictive factor that they're going to have chronic release stress hormones. How much this has occurred over time, and then adversities following the trauma. And so we think about families that really struggle. So say you had substance abuse in the family that led to physical abuse of the child. So you have multiple traumas. Now the child's removed and put in foster care, and you have loss of parents and a third trauma. So that is those kind of histories you see a lot. But as we said, adults who can offer reassurance and protection. What we want to do is build up the parent, family, grandparents, other people early in life, right around the child. Penguins are cute. They're incredibly resilient. You know, how the heck do you live in the Antarctica and walk around and sit on eggs all day? So just to put up a definition, it's not only the capacity to thrive under stress, it is the strength and ability of families, schools, and community to provide children with the things they need to adapt and thrive. So that's a lot of how we try to describe the direction we're trying to move. And those relationships between medical and education and community really make a difference, and communicating back and forth helps out a lot. My way of explaining some of the things we talked about earlier, and I'll just put them up, is the downstairs brain is that fight or flight or freeze. And it can be, if it gets worked out a lot, it grows like a muscle and it's dominant. The upstairs brain helps with problem solving, helps you calm down. I think it almost is giving a hug to that downstairs brain and saying, it's going to be all right. So how do we grow that upstairs brain? And then trauma, as we talked about, leads to that reactive style. Everything that's already been said, I'm not going to repeat a lot of it, but feeling connecting, feeling nurtured, and appreciated, feeling some control over one's life. That's something really starting to work with parents. Actually, even just in medicine, trying to get us better to be shared decision making is the same model, instead of just telling patients what to do. But it's hard to drag these doctors along sometimes. The other line I'll use is serve and return. When you are positive and have calming influence on the child, you will get a return. There will be neurogenesis. And their brains are incredibly malleable. Ours are relatively fixed. So it's that never give up mentality. So raising readers, so how do you use it in practice? So raising readers, We get incredible books, developmentally appropriate for every well-child visit from 2 months up to about age 5. And so what I'll use is try to, demonstrate and talk about, always talk about the brain development like Dr. Gabe was mentioning, and then these special moments where you are being calm with your child and giving them uninterrupted attention and helping them really feel connected. So, and some of the other things, so resiliency, being like the older child, getting a role in solving some problems. And it can be very simple, like, do you want to read now or after you brush your teeth? Just trying to help parents through that so you're not butting heads all the time, and give the child some choices, which book you want to pick out. If they want to pick out the same book for the 32nd time in a row, great. They want to be, 2 or 3 books tonight. The other thing is to then start to use the stories to help teach the child and brainstorm in the moment. What would Dora want to do right now? What should she do next? What do you think? And even though he knows what Dora's going to do because you read it 40 times, it's still, a good way of brainstorming some, problem solving. Feelings is another one that really trying to get parents to get their kids talking about feelings. So you got Diego's upset. He broke Dora's favorite toy. How do you think Diego feels? Have you ever felt that way? What should he do next? So just really teaching some parents that natural problem solving. Reading is not just reading the book. It's the whole interaction kind of behind it in that young age group, which I probably shouldn't be telling you all that because you are much more advanced than we are in it. But really trying to make it fun for them. You don't even have to read the same story. You can make up a different story together. Another one we started talking about in our clinic is mindfulness. So you're going to sit down with your child to read. Take 5 breaths always before you start the book, and you can either do it with the child on your lap, or if that's too stressful for you at first, do it before you go get the child to read your book. And then children pick up so much what's the stress level of their parents, and so you kind of become one, and you really work on that breathing throughout it. And then hopefully it's a skill that they can teach their own kids, and kids can learn those types of meditation or self-awareness at an incredibly young age. Routine. So typically traumatized kids do not have routines. And they talked about that with sleep and other routines. People love to read before bed. Let's expand that, like do it 3 times a day, 4 times a day. It doesn't have to be long, but put it in there, put it into your day. And they can really be part of it, and ask them to be part of whatever routines are going on, of cleaning your plate or picking out the snack to go, veggies you're going to have with dinner or fruit. And it really helps them learn better control, tolerate frustration if they have routines. For a lot of families, it can be very difficult at first if they haven't had those things built into their lives. And the kid, so take it very small steps is the best approach. Trying to get away, and he was a much better speaker than me about that, the kind of reward punishment to skill development. And so, change the parents' thinking from won't behave to can't behave, and how do we help them learn some of the skills. Talked about the feelings earlier, and really using books to kind of start to practice having that discussion, because it might be very difficult in the moment when the child is angry and yelling and crying to be able to then, it's too hard for that parent to talk about feelings there. But in a book, it's a little more objective, and they can start practicing those conversations. So always try to talk with parents, lead by example. And you got to try and try again. As the speaker mentioned, you don't have to be perfect at this. You just have to be enthusiastic. And then, as he said, is that self-motivation and the positive experiences. And that they need adults. That's without question. And really emphasizing it from those earliest visits is the change that we're trying to kind of put in place. And then families who need additional support, we have to figure out ways to bring it to them. All right.
Transition back.
Yes.
Sure.
So you just said that you try to lead parents who need skills, you try to lead them to support. What would you say as a pediatrician?
So, and I'll talk about it in the later part, kind of how our structure is. But we're redesigning our care teams to be able to have integrated behavioral health clinicians, case management, links to community resources. That's different than what I think traditional offices had.
Yeah, yeah, and again, we'll probably, hopefully, both allude in just a little bit more about the kind of final part, which is trying to explain how some of medical practices we hope are changing, and what we're trying to do, our small role in the medical world, to push some of the things that we know are helpful. So I'm going to transition back to me. I'm going to bring it back to, you can tell who does a little more work in what different areas. I'm going to come back to the some more in the way of like evidence behind the kind of that not just the early relationships that can be developed from early shared book reading and a promotion of reading early in life, but I'm going to jump into the realm that you guys are probably more familiar with, about how it promotes literacy, and then how that can help to lead into resilience, right? So I'm going to highlight a couple studies and then talk a little more about it. So this is a study in child development that looked at parental involvement in the development of a child's reading skills. Longitudinal study looked at 168 middle to upper class families, and I've underlined the result that I wanted to highlight, which is that children's exposure to books was related to the development of vocabulary, listening comprehension skills, and these language skills that directly related to reading proficiency in school later on. Again, when you follow this, again, coming back to the concept of when you work on these things here, you end up getting the results here. And then a couple more interesting facts from studies. So children's exposure to books was related to the development of vocabulary and listening comprehension skills. These language skills then directly related to children's reading later in school. Again, just another point. You put in, again, I think it's like the point of this, all the early brain development, early intervention. You put in the work here, you get the benefit down the road. And then children who are consistently read to are more likely to grow up to love reading. Duh. A couple other little interesting facts. So children's books contain 50% more rare words than like television or even like college level conversations. I think we probably don't realize how little vocabulary we actually need in order to communicate with each other verbally. And so that shared book reading can really stimulate more in the way of verbal interaction, both between the child and parent, again, getting back to what Steve is. But it's not just that, it's an increased level of exposure from a vocabulary standpoint. And then children with a greater vocabulary knowledge and understanding tend to have less trouble with reading. So again, this is kind of like the circle. So the unfortunate part, that I think, is a little alluded to, is that 1 in 3 American children start kindergarten without the skills that they really need to learn to read. And so, and this is plucked right from, I'll say, from a medical community standpoint. Actually, the American Academy of Pediatrics, I think, each year picks a particular area of child health to focus on each year. And 2 years ago, it was early literacy. And I plucked this right from the American Academy of Pediatric website. Thankfully, a lot of evidence about shared book reading increases that early literacy, translates to better reading and communication skills. And again, I would think about communication skills being kind of a crucial part of any toolbox for resiliency, right? How do you promote a way for a child to express themselves? We talked, again, I couldn't have thought of a better keynote to lead into this presentation, which is like, how do we remove roadblocks for kids? Like, how about we promote ways for them to healthfully express themselves? Why don't we give them the skills? So giving them a head start with early literacy skills, it's not a step too far to think about how, promoting that early on leads to an increased improvement for at least the prospects of early educational success. And how could educational success not lead to confidence? Again, these kind of things which ties into what are the things that we are doing that help to build the ability to be resilient against some of the potentially negative effects that these children can also see in their lives. So I'm going to switch now and start the conversation around, so what are we doing, what should we be doing? What are we trying to help promote in medical practices, pediatric practices in particular, but anywhere where children are being seen early on in life. And the concept of why it's, this is a little talk about like what I'm trying to talk about with providers too, as I'm going around trying to stress the importance, is that medical providers to some degree have some unique access, relationships, and expertise to talk with parents about this stuff, right? So the talk started with like early on, and they may not end up in schools until kindergarten, right? And so that's 5 years. That's 5 years of critical time that they don't have an educational specialist that's in their lives. But we're seeing them at 2, 4, 6, 9, 12, 15, 18, like many times through early life, often with parents that we might know from another child, or we get to know because we're seeing them with reasonable frequency, even if those visits are short in the grand scheme of things. And most of the time, parents respect opinions of the pediatrician or child care provider, primary care provider that they're going to. So simply giving some advice most of the time lends at least a little bit of weight in what we're talking about. So this is a little survey study that looked at the opinions of over 2,000 parents about reading habits of young children, and looking at a number of factors, and found that daily reading, so reading consistently, which I just mentioned from all the other evidence is a good thing, was related to maternal education greater than high school, greater number of children's books in the home, and a discussion of reading by a pediatric provider. Those were the things that came out as positive predictor values. It's like, all right, I can't do much about a maternal education greater than a high school, but boy, can't we do something about those other two things? And again, this is what I'm trying to present as a case to other providers, and illustrating, that we really can have a role in this. And then I'll highlight a couple other studies that were published really based on by providers that use the Reach Out and Read program, which is very similar to the Raising Readers program, except for it's in other places other than Maine. We're just fortunate enough here in Maine to have a program that is funded in such a way that it's provided for everyone. There's the Reach Out and Read program that's in other states. Practices must pay for the books that they get if they participate. So anyway, so this in particular is a controlled study, evaluating a clinic-based literacy program that I just mentioned, the Reach Out and Read program, looking at a number of low-income families enrolled in both an intervention and control group. Families in the intervention group read more on average. You can see there, more days a week and more nights a week. And then the parents that in the intervention group, which received basically what we do with Raising Readers, which is books and messaging around the importance of early literacy. The children were more likely to list reading as one of their favorite events, activities in childhood. And then they actually also showed that they had higher both expressive and receptive vocabulary scores in those toddlers that were in the intervention group versus in the control group, which got standard care, which means no books, no messaging about the importance of early shared reading. One more sample control study of the impact of literacy intervention. Again, this is around Reach Out and Read program. 122 families this time. Again, families in the intervention group read more, on average, one more day a week. And the children in the intervention group had higher receptive and expressive language scores, what amounts to a 6-month developmental difference. So, that's pretty significant. Again, speaking to the point of how are we trying to give these kids a head start for success and ultimately more skills. So I'm highlighting some of the things, again, that we're trying to get out there to other practices. So if possible, making the office and exam rooms literacy rich, books available. I can tell you that one of the things that actually helps to thwart this sometimes is the infection control measures that some practices have to take place. So you may notice that around flu season, like all of a sudden, like everything disappears from exam rooms and waiting rooms. There are probably some pretty decent reasons for that around infection control standpoint. But when you can, trying to be not just in your verbal messaging, but as a practice, being able to be more literacy friendly and promoting. So have books available, have them around, have the children that are waiting there be able to, pick them up, explore them, have them. So, and then front desk staff, anyone can, it doesn't have to be even the provider, trying to incorporate this into the rest of the practice about an excitement and enthusiasm around reading early literacy that doesn't have to come from just one person. There's all kinds of things that we've talked about doing, and Steve, actually, you started to mention some of the ways that we try to use both the Raising Readers program and the books to try to help promote the messaging. So I know I'll speak in I statements here. I will often give the book very early in the visit and use it as a vehicle to try to both promote the messaging, and it's also helpful for us in that when they whatever the age of the child, and as you can imagine, we're seeing the breadth of different ages early on in life with some frequency. Observe how they interact with it. How do the parents interact with it? You can actively, present the book to the child. For older children, start with, trying to do some naming of things. Point to the blank. You can use it as a developmental tool as well. Talked about developmental comments. It's a multi-purpose thing. You can. I have a lot of parents come to me. We talked about promoting reading routines. Like everyone can talk about, oh yeah, read before going to bed. Our parents say, I can't read to this toddler. They're all over. They can't sit down for any amount of time to read. What am I supposed to do? I can't read to them. They eat the book. They can't. So all the young age groups, Raising Readers, we talked about developmentally appropriate books. All the young books are board books. I don't care if they eat the book. Chew on the book. Explore the book. I don't care. We're giving them a new one each time they come in. And also the being creative around it. So I talk about like hey, your child won't sit down to read an entire story? That's okay. Read a page. Let them go. Or, like, I don't know, read during bath time. Where are they going? They're in the tub. Read during meals. Like, they're in a high chair. Like, there's lots of opportunities for messaging that in the past probably providers have missed out on, and that it's just a matter of bringing it to the consciousness of helping to give parents ideas about both importance and strategizing their own roadblocks about how to get to the point where they're incorporating this. So in Maine, you guys probably know all this. The Raising Readers has done a little bit of their own research around, at least around attitudes, and from survey information, parents, 35% of parents report that reading more to their children as a result of receiving books, Raising Readers books in their primary care offices. 53 parents report that they visit the library or bookstore for their kids, attend a story hour, which is great. And then healthcare providers that were surveyed, even, and this is now, this is older information now, but 79% of parents reported that their healthcare provider talked to them about reading to their children. So I was a little encouraged by that. That's pretty good, I thought. So getting back to the gift that it is. So it's really, they're giving books and promoting reading in all of really all the medical practices in Maine, which is pretty amazing considering the disparate health systems and everything else that are involved in healthcare delivery. Just giving out a crazy number of books. And as I mentioned, because it's funded by the Libra Foundation, unlike the Reach Out and Read program, which is also great, but requires that a practice makes an investment, this is free to both practices and all the children of Maine. And it's great. They receive, 12 really great books. I absolutely love, this is me with one of my real patients I got permission to use for this, displaying what literally I do every visit, which is I give the book at the beginning of the visit, talk about the importance of early shared book reading and literacy, watch the child interact with the book. I even do some play with the book often, sometimes. It's great. And I think it's helpful. I think it moves the needle some, which is, that's what we're trying to do, move the needle some. And also getting to the resource standpoint, they also provide a website with books and lists. You talk about using the book more than just for the reading standpoint. So Raising Readers will provide books, on their website, which I refer parents to, will provide books that are like one, they provide information in different languages, which depending on where you work, can be really helpful. But the other thing is they'll provide resources for like books on certain topics that are difficult to talk about. Getting back to what you talked about, like, there are books on divorce and, sometimes it's just easier to go through that process when it's being read in a book as opposed to this kind of sit-down conversation with a child, for instance, right? Or books on, other difficult situations. So books on potty training, books on all kinds of things that they'll have lists for different issues that you can then use for directing parents to, or as providers, we can go and look and say, hey, what might you recommend to a family who's going through this? Great, so that's a little bit how I try, and I'm also trying to promote through medical care, both through Raising Readers and through doing this, this talks. And I can say that, for example, like I gave a talk with a lot of some of the same information at the Maine chapter of the American Academy of Pediatrics conference. I think it was a couple years ago now, and have gone out to different, actually residency programs and different practices to talk about, you know, early on in education, getting the messaging out there about what the evidence really is behind making this a priority in the medical setting as well. Steve, I think you have some more. Getting back to the point, and Steve's going to talk a little bit more about your question, I think, which is, okay, great, we know this is some of that, my stuff is kind of intuitive, great, but how are we going about it? What do we do about when the adverse stuff comes up? So.
Everyone want to stand up for a second, just to stretch out a little bit. This is a long talk.
And I was walking by the downstairs hallway, which is EKK 1 and 2, and a 4th grader was walking by the shared book box for the younger kids, and he like flipped out. And I said, Drew, what's the problem? Can I help you with something? And he said, that's my book. My doctor gave it to me. His mother had done a cleaning up 5 children, and he was very upset. And I said, Drew, that is your book, and I'm sure that your mom didn't mean to upset you. You can take that book home. And he was like, I need to look through the rest of this box because she may have given them all to the school. But it was very important that he take his book from his doctor home.
Yeah.
That's great. He probably thinks that,
And he's a 4th grader.
that I've had patients who think that I'm just their doctor. Like, you know what I mean? Like, wait, you take care of other patients? All right.
And that speaks to another thing, which is like other strategies that you can make it special and important. Like some providers like sign their own name in the book because you know that kind of makes it special. Like, this is your book from me.
He made it very clear that he was a lot older than this book was, but that the content wasn't for his age, but he needed to keep his books. So I said, I'll call your mom, it won't be a problem. She was like, whoever would have thought?
Right.
I said, you just never know.
So I was going to put up, so our mission that we're trying to push forward is prevent, identify, and treat adverse childhood experiences at Maine Medical Partners primary care practices. We have 3 main components. So understanding, we have educational components to all staff members, front desk, medical assistants, nursing providers, integrated behavioral health clinicians, and towards parents and the children themselves. Recognizing, and so by teaching providers about ACEs and symptomology so that they might recognize it when a child presents with frequent, might be constipation, abdominal pain, headaches. You need to do your medical thoughts, but there's also trauma can present with all these things, or the behavior side. And then we are developing screening tools to try to bring these issues to light so that they can be addressed. And then once they're brought to light, yes, what support can we provide to families? So we have all different ways we've done education. We have a website that has we have an online learning module. We have a toolkit and resources that can be printed right off of there. We offer in-person trainings. We do online trainings that practices can call into. We've done a lot of trainings throughout the state for the integrated behavioral health clinicians and the trauma-validated treatments. And as I mentioned, the webinar. Just going to show you some of the tools that we started to use. So everything we do, we build into our electronic medical record and put out workflows to try to be consistent. And so we went from kind of the standard, do you feel safe questions that medical assistants would rapid ask to these 2 questions. Has anyone hurt or frightened you or your child recently or in the last year? And has anything bad, sad, or scary happened to you or your child recently or in the last year? So these are asked at child visits. So Gabe kind of outlined how often those can be asked. Our recommendation is it's handed out on a non-identifiable, we do it in a laminated with dry erase. So it's a little less personalized in a way, instead of having someone ask you that kind of question directly and rapidly.
How often does the patient decline?
Not often. But they're given, that's part of the training, is that it's absolutely fine, and you don't have to answer it if you don't want to. But we've not had major pushback from that side. If it is positive, pediatricians were not trained about post-traumatic stress disorder. Like, we think of war and post-traumatic stress disorder. So a lot of what we try to do is build up their skill set. And so we have a tool we built in that's validated, that's quick, 6 questions, and it's for younger kids, and there's a version for older kids. If it is a significant trauma, use this to figure out symptomology. 1, you have to, how worried am I about this? And 2, it helps educate the parent, because parents are like, oh, he's fine. And then they answer that like, ooh. And then we build in information that can be given to the parents. I don't have time to show you a lot of the data from it. Things we found out by handing it out, it tripled the rate of positive results. When it was asked by a medical assistant, it was about a 2%, 1 to 3% rate of positive, averaged 8 to 12% if we handed it out. And then we looked at 500 charts. We hit pretty much every major type of trauma that was identified. A lot of more common types, but everything from kidnapping and abuse and finding a person who had overdosed in my house to, it just went on and on. These things are occurring. The second tool that we put in place is called the Survey of Wellbeing of Young Children, developed out of Tufts University in Boston. And this goes back to that early slide of developmental delay risk and how important it is the environment. Most developmental screening tools only ask about where's the child right now. So this one does that, but also then asks, it's called the Pediatric Symptom Checklist, to look at behavior, emotion, parental difficulties in the kind of child-parent interactions. And then it has a whole area that tries to start to screen for a lot of the different ACEs. I'll just show you the tool that we are using. So it's a brief developmental screening. Good, very short, reasonably low literacy question, so it's easy to use, easy to score. Behavior, it looks at kind of dealing with change and tolerance of that, irritability, and kind of difficulty comforting your child, and routine. And you think about early parenting, those are the 3 main components. So looking for areas they're doing well, looking for areas that we can help address. The last section is a kind of takes an ACEs lens. We already were doing tobacco screening. I mean, it's amazing, not amazing, but up to now, we never screened. Was there alcohol or drug risk in the families, really? We didn't have a way of consistently going after that information. So there's multiple questions about that. Food insecurity shows a high level of stress on a family. So helping them if there is there, but also using it as a marker of stress. We do a PHQ-2. We think about postpartum depression, but the impact on the child at a year is just as bad as an impact on a baby. And then we started trying to put our foot into relationship difficulties and stress within a relationship. Very difficult in a pediatric office to screen for domestic violence, but trying to at least start to bring that conversation forward. What we found, just to give a little, the rest of the SWIC, they validated themselves when they developed it and showing that developmental screening works, the Pediatric Symptom Checklist, their MCHAT screening. This section, they took validated tools and smushed them together. And what we found from Maine Medical Partners is that we were only getting about a 2% positive rate outside of the smoking question. So it really wasn't impacting the practice like we wanted it to. We know from the CDC data that 2% is not correct. So what we're moving towards next is an actual adverse childhood experiences questionnaire developed out of the Center for Youth Wellness in San Francisco by Nadine Burke-Harris, who's a lead in the field. And what she did, which I think is incredibly clever, is instead of saying, asking these individual things, you just look at it and you write the number in the box. So you de-identify it some, pull it back a little so it's so not in the face and so almost like even traumatizing for the family. And then because we know the number actually has incredible predictive risk factor associated. So a 1 to a 4 is incredibly different. If you're in counseling and therapy, it's going to be important which ones those were. In the pediatric office, actually what we do might not be it might not make that much of a difference which ones they are. Once you're at a 4, we know the risk is high, and we need to start bringing more resources and helping those families more. So we have just started rolling this specific adaptation in the last month. We also, Maine Medical Partners has a care team model now, which is a change. So it's not just the provider and the nurse or medical assistant. It's a provider an integrated behavioral health clinician who can provide validated counseling treatments, and some case management resources to help connect to food, housing, legal, transportation. And so by having that, it enables us to start to screen. Kind of this is what we're hoping our future state will look like. So before it was a really big circle medical provider doing it, a little bit of data, and a little bit of behavioral health. We're trying to grow those circles almost to the same level and putting the family in the middle. I didn't talk about data much. This is kind of the other change. So families who on the SWIC screen positive, and I refer to behavioral health and child developmental services, hits a registry that the pediatricians can review and see everybody they were concerned about in the last 6 months and say, oh, did they actually connect with child developmental services? Did they connect with behavioral health? Did my case management help them? Because there are gaps all over the place in communication and being able to help these families through this process. We have a fantastic partnership with Child Developmental Services, and we have I think it's quarterly meetings now where Child Developmental Services, healthcare at home, practices, preschool all come together to really work on our ability to communicate together to try to close those gaps. And I think that's an area that schools and providers can also try to start improving. Oops. Is that me or you for take-home points?
I think that,
yeah, I think you're going to wrap it up.
Oh, wow. Yeah, so as I mentioned at the beginning, and I'm not going to stand up for one slide. As I mentioned at the beginning, there are some aspects that are really different about the topics that both Steve and I were talking about today. But they're kind of at least loosely related in that, I think that there's plenty of evidence to show that early shared book reading is important for the developing brain. ACEs are common risk factors for poor health outcomes, and that the early shared book reading and the literacy promotion that the Raising Readers program helps to promote connection, positive shared experiences, literacy, confidence, and at least goes a little bit in the way of trying to address what are the things that we can do to try to help promote resiliency and minimize the effects of the adverse experiences that unfortunately so many children are exposed to. And that as pediatric providers, we play a small but important role in screening, both screening for ACEs and providing intervention, for those that are screen positive, and for promoting resiliency. One of the ways that we do that is try to help promote literacy. And one of the biggest tool for that is through the Raising Readers program that is in place. And so I think we're actually ending earlier than I even expected. So we're ending earlier here. Plenty of time for questions, as you can see. And if there's not, then we'll get you guys going early.